As we know, the dangerous of the complication of diabetes mellitus and other systemic diseases. The diabetes is considered one of the serious and dangerous systemic disorders, and therefore the neglection of the treatment or the location of the disease itself, there is a vascular affection, of course, will be occurred. The next discussion is a very important discussion in which we will facing a debate between two professors. We are so glad to introduce them. الأستاذ الدكتور هشام شرف والأستاذ الدكتور محمود صلاح. The discussion about the tibial revascularization, is it a single vessel revascularization, dilatation, or a multiple vessel intervention? We will start the debate, which I so glad to start then with الأستاذ الدكتور هشام شرف.
Thank you very much, Mr. Chairman. First, I want to thank the organizing committee of VOT and welcome all the guest speakers from all over the world to Egypt. I hope safe stay and good time. Now I'm discussing this challenging cases with food ulcer due to ischemia. I said the first, the single tibial artery angioplasty and management of ischemic foot ulcers. As we all know, the prevalence and presentation of CLI is ischemic wrist pain, ulceration, or gangrene, and its complication leads to amputation. Before we start the concept of single tibial angioplasty, I want to discuss the angiosome of the foot and direct vascularization of the foot. There are 6 angiosomes. The dorsum of the foot supplied by dorsalis and the anterior artery, the lateral ankle by the lateral calcaneal branch from posterior tibial artery, and the plantar and the medial ankle from the posterior tibial artery, and also the plantar voral and the lateral plantar forefoot from the posterior tibial artery, with the branches from the peroneal artery to anterior and posterior tibial arteries. So there is direct revascularization and the indirect revascularization, and the success of ulcer healing depending on the presence of patent arch till the tibial vessels and popliteal artery. The variation of foot arterial arches is very important to note that the deep plantar arch originates from the posterior artery through the lateral plantar artery, while the dorsal foot arch from the dorsalis medius artery. Also, there is atypical or abnormal anatomy, as Dr. Samer mentioned. Plantar arches and plantar artery were observed in 5% of cases, whereas arcuate artery and the deep and dorsalis medius artery variant were present in 6 to 8% of cases. This is the diagram of the complete arch of the foot, and this diagram representing the success of the revascularization of the foot ulcer. And also this is the anatomy of the plantar deep and the superficial plantar arches of the foot. And this is some abnormality that the lateral tarsal artery may originate directly from the dorsalis medius artery or from the arcuate artery. So when we do angiogram before dilatation, we must know the normal anatomy of every patient, which may be different. This series of cases was assessed as single tibial artery angioplasty in critical lower limb ischemia in Rutherford 5 and 6. Patient presented with ulcer or gangrene, and our primary outcome is the rate of the wound healing, and secondary outcome is the primary patency and limb salvage and 30-day mortality. So about 110 patients was admitted to this study and classified to single tibial and multiple tibial vessel angioplasty. We exclude patients with severely infected limb Arteries with chronic ischemia, Rutherford 1 and 2 and 3. 4 Rutherford, patient with known history of dye allergy, patient with severe renal impairment, and we will follow up the patient at 1 month, 6 months, and 3 months. This is a case, one of our cases with anterior tibial occlusion, and this is after successful angioplasty and healing of the ulcer in the big toe. Another case with the gangrene of the stump after TMA, and we dilating the anterior tibial artery till the patent arch, and we can show the presence of patent anterior and posterior tibial artery and the healing of the ulcer. This is the healed ulcer with occlusion of the distal part of the posterior tibial artery, and this is after debridement and good revascularization of the ankle. Another case with severely infected heel ulcer, and after revascularization there is a complete arch as we see in the left side, and this is the good granulation tissue after debridement of the gangrenous parts. Throughout the results, this is the most common risk factors present in our patient, like smoking, the hypertension and diabetes, and also the clinical presentation in the wrist pain and ischemic ulcer. The patency rate, there is no difference after dilatation between the two groups, either single vessel or multiple vessel. And this is the log-rank test for the recurrence of stenosis. There is no significant difference between the two groups. And this is the change in the ankle brachial index after angioplasty. There is marvelous changing of the ankle brachial index and improving of the ankle brachial index about 0.4 after angioplasty. So this is the after single tibial angioplasty. My colleague Dr. Mahmoud Salah is so happy after doing single tibial angioplasty, and unfortunately when we have dissection after multiple vessel tibial angioplasty due to heavy calcification, as we see in most of our patients with renal impairment and atherosclerosis. This is the picture of my colleague Dr. Mahmoud after there is dissection and the problem. So my conclusion, we found that CLI patient with tibial arterial occlusive disease, single tibial angioplasty till the patent plantar arch was not inferior than the multiple tibial arterial angioplasty as regards ulcer healing, limb salvage, and amputation-free survival. We need further studies with large sample size and longer follow-up period to confirm the theory that in critically ill patient with CLI single tibial angioplasty with patent arch is enough for limb salvage. The least is the best. Thank you very much for your attention.